there were still some skeptics, and I would have had included myself as one, because we had not seen overall survival, and we knew that this was a global trial where routine PET imaging or PET simulation was not employed. And there was always a concern that perhaps in the absence of PET, many patients who would otherwise seem to have stage 3 disease, in fact had stage 4, had otherwise occult metastasis that had not been detected by PET, and of course durva would do far better than placebo in that setting. All of my concerns have been assuaged. There was a recent press release citing a significant overall survival benefit. We haven't seen that in 15 to 20 years, no matter what approach we use. And we certainly look forward to the unveiling of those data, which I believe will happen at World Lung in Toronto in September. So as far as I'm concerned, the standard at this point is durvalumab after chemoradiation. This is in contrast to other immunotherapy approaches, including vaccines, as well as other agents that have just flat out failed. Intriguingly, at ASCO this year, there was a phase 2 presentation by the Who's Your Oncology group looking at pembrolizumab in the same setting. So essentially the same design, concurrent chemoradiation followed by pembro. It was not randomized. The data look as good, if not slightly better, than the data generated by durvalumab. So that durva at this point is state of the art. Doesn't mean that other checkpoint inhibitors won't work as well or perhaps better. I anticipate studies that will look at the combinations of checkpoint inhibitors, so CTLA-4 inhibition with PD-1 or PD-L1 inhibition, and of course moving it forward, giving the checkpoint inhibitor during radiation rather than delaying it to the consolidative setting. So that is really where we are going with locally advanced non-small cell, and it's very gratifying to see an advance of this sort after well over a decade of fallow research.